Pathophysiology, it's an infection of the lower respiratory tract caused by bacteria, viruses, fungi, protozoa, or parasites. It is the eighth leading cause of death in the U.S. and is responsible for more disease and death than any other infection. It can be categorized as community-acquired, healthcare-associated, including hospital-acquired, or ventilator-associated pneumonia. Healthcare-acquired pneumonia is defined as occurring in individuals with recent hospitalizations in residences in nursing homes or extended care facilities. Those most at risk include the elderly, smokers, alcoholics, and those with nutritional deficits. There's two types. Viral, infecting viruses include influenza, adenovirus, respiratory, synctival virus, and the pathophysiology is usually a complication of the upper respiratory infection in which the virus spreads to the lower respiratory tract. The virus destroys ciliated epithelial cells and invades goblet cells and the bronchial mucus glands. Sloughing of destroyed bronchial mucus glands and epithelium impairs the mucus clearance by the cilia. Bacterial is infecting organisms that include gram-positive bacteria, which would be Streptococcus pneumonia, Klebsiella pneumonia, Staphylococcus aureus, and gram-negative bacteria would be E. coli, Pseudomonas, Haemophilus species, Proteois species, Bacteroid species. Those are just a few. The pathophysiology, as bacteria is multiplied and the inflammatory process progresses, pus accumulates. This results in a process of consolidation in which the alveoli become filled with pus. The body's defense mechanisms, in addition to the inflammation, include coughing to expel that pus. Signs and symptoms. The affected individual usually has a toxic appearance with fever and malaise. There is a moist and usually productive cough with brilliant mucus. There may be respiratory distress or hypoxia. The etiology. The development of hospital-acquired pneumonia represents an imbalance between normal host defense mechanisms and the ability of microorganisms to colonize and then invade the lower respiratory tract. Other symptoms include chills, malaise, and pleuritic chest pain. Physical examination may reveal signs of pulmonary consolidation, such as inspiratory crackles and increased tactile firmness, palpable chest vibrations, agophony, prolonged A over consolidated lung tissue when the person is really saying E, and whispered ventriloquy, the sound of whispering heard over auscultation on the consolidated lung tissue. Evaluation and treatment. Diagnosis is made on the basis of history, physical examination, white blood cell count measurement, and procalcitonin or C-reactive protein level, and a chest x-ray. Stains and cultures of blood and respiratory tract secretions are completed in more in severe hospital cases before the start of any antibiotic therapy. Serum procalcitonin or C-reactive protein levels can be used to help differentiate bacterial from viral infection in order to guide therapy. Once the diagnosis of pneumonia has been made, the pathogen is identified by means of the sputum characteristics such as the gram stain, the color, the odor, and cultures, or if the sputum is not able to be withdrawn, you can do blood cultures. Now remember, you got to differentiate between whether or not this is left ventricular heart failure or pneumonia, so you would do echocardiograms and ventilation perfusion scans that can help differentiate between these two. The microbiologic approach to diagnosing ventilator-associated pneumonia include the preferred non-invasive methods, such as collection of spontaneously expectorated samples, sputum production, and nasotracheal suctioning. Endotracheal aspiration in a patient with ventilator-associated pneumonia is considered non-invasive. Treatment. So the first step in management of pneumonia is establishing adequate ventilation and oxygenation. Adequate hydration and good pulmonary hygiene like deep breathing, coughing, and chest physical therapy are also important. Antibiotics should be given within 4 hours of presentation of bacterial pneumonia. Empirical antibiotics such as Zosyn or ampicillin are used in ventilator-associated pneumonia, and according to the 2014 National Institute for Health and Care Excellence, recommended only to give antibiotics when the C-reactive protein level is greater than 20 millimoles per liter, with positive clinical findings. Antifuncals such as fluconazole may also be necessary. Prevention measures include prevention of aspiration, respiratory isolation of the immunocompromised individuals, vaccines for anyone over 65 years old, and reduction of ventilator-associated pneumonia can be done through the variety of methods such as oral hygiene and endotracheal interventions.